I'd like to introduce Dr. Christoph Troppmann. Dr. Troppmann completed his medical school training in Germany and then came to the U.S. And did his residency and fellowship in transplantation at the University of Minnesota. And he joined our team in 2000, so I've had the pleasure to work with him for the last 13 years. And he's going to talk today about expanding access to transplantation. Dr. Troppmann?
Thank you. First, good afternoon, and I'd also like to express my thanks to Linda and her team and the association for inviting us and giving us the opportunity to speak here to you. What we'll do is I'll give you a presentation about our transplant center, about our transplant program, about our outcomes. There are also specific questions that I had the opportunity to be provided with ahead of time by your association that were of interest to you and the board of directors, and I'm going to go through those as well at the end. And then I will obviously be available for any additional questions that are left over thereafter. So we're going to get started. Can everybody hear me? Everybody can see the screen, hopefully. So this is Sacramento, and you can see that this is our medical center. And I'm going to talk a little bit more about that in a couple of slides. It's really grown tremendously just over those 13 years that I've been there. We're going to talk about briefly about our transplant program, about our health system. And then really the key question for this group here is how do we maximize patient access to renal transplantation? And we're going to look at it separately by the two big types of donors, the deceased donors and the live donors. And then I'm going to end this off as far as the slide presentation is concerned by going specifically to the questions that the board has graciously shared with us ahead of this presentation. So we're obviously part of the 10-campus University of California system. We're part of UC Davis, and UC Davis is the 7th ranked public research university in the United States. This is our medical center, and this is actually only part of it. Again, it's grown tremendously since we're doing clinical work, a heavy workload of that, research and education. We're medical school for the last 45 years or so. We have a 619-bed hospital, 1 million outpatient visits per year, 32,000 admissions, a lot of very dedicated, specialized disease programs, cancer, burn unit, level 1 trauma center, the only one in inland Northern California, and we are also made it into U.S. News and World Report as being one of the top 50 hospitals nationwide. But we're not only providing clinical patient care, but we're also a leading academic healthcare system with a lot of research. There's been a lot of dynamics in the last 10 years. We rose from 62nd in terms of the public research funding in 2001 to number 36 in 2011, and the trend keeps going in the same direction. A lot of interesting research going on, basic research in collaboration with the campus, but also on the medical school itself, in the areas of cancer, injury, wound healing, and also what's important for the transplant area of stem cell research. As you may know, by the California Institute for Regenerative Medicine, funded through a state grant, one of the institutes is actually in Sacramento. At the time, this was a big deal, a lot of competition for that, and we're very happy to have it on our campus now. And then the other part of academics is obviously training the next generation of physicians and of healthcare providers. We have a nursing school, and we have 57 residency and fellowship programs with over 800 residents and fellows. So it's a busy academic medical center. Now let me talk a little bit on a couple slides about our transplant program, since most of you may not be that familiar with it. We've been around for over 30 years and continuously operating during that time. In 1992, we added the pancreas transplant program. In 1997, we performed the first laparoscopic live donor nephrectomy through minimally invasive means on the West Coast. Since 2010, we've become the largest pediatric en bloc renal transplant program in the United States. I will show you a few slides down the road what that means and what that is. In 2012, we became the largest deceased donor renal transplant program in the United States in a tie with UCSF. And in 2012, we were one of the only 8 centers, transplant centers nationwide that were looked at that received the Kidney Transplant Excellence Award by the Health Grades organization, which is a not-for-profit organization. You can look up, you can Google that, and it'll tell you all the criteria that we looked at. It was mostly based on actual outcomes, publicly available data. Our transplant center, I'm very happy to say, is also been growing over the last years tremendously. If you add all these numbers up here, we're looking at over 50 professionals that are exclusively and full-time dedicated to providing care to transplant patients through all the stages. On the pre-side, the actual transplant event, and then on the post-side. A lot of these, I would say the vast majority of these individuals extremely experienced, like Michelle Sturgis, for instance, who's been in the transplant field for over 25 years. 3 out of the 4 surgeons have been in the transplant area or doing transplants for the last 20 years plus, and on and on and on. So that's just to say that we have a lot of support, a lot of people that work exclusively with transplant patients. We obviously also have the infrastructure needed in order to accomplish all that by having a specialized transplant inpatient care unit. We have specialized ICU beds, critical care unit beds available for those that need critical care for a transient time after their transplant. And importantly, I think probably also to interest to this group here today, we have multiple outreach clinic sites in Northern California. In those outreach clinics, we perform pre-kidney transplant candidate evaluations, but we also do some of the post-transplant care in kidney recipients. However, I want to say for full disclosure, we're not going to be seeing you in our outreach clinic 2 weeks after the transplant when you still have a fresh incision and you may have some other issues going on. We do our outreach clinic post follow-up care by and large in stable patients that are more than 3 months out from transplant. The red stars are all our outreach sites here in Northern California. Of most interest to this group here perhaps, we have every Friday a outreach clinic, a full day outreach clinic in Walnut Creek. So a pretty close geographic proximity that's staffed by one of our full-time transplant nephrologists that comes specifically down for the day. Where do we stand at? This is 2012 publicly available data. All the data I'm going to show you here, with few exceptions, is all publicly available on the web. Transplant is a very transparent specialty by design. The government, when the National Organ Transplant Act was passed, made it such that transplant results from all the centers get published on the web almost real time in order to maximize trust of the public in the transplant system, and I think that's the right way to do it. So in 2012, for adult kidney transplants, adult recipient kidney transplants, we were the 4th largest program in the country. And I think the important part here on this slide is look at the fact that in the country, among the first 3 of those 4 programs are located in California. If you look at the first 20, you have Cal Pacific and Cedars-Sinai. What that really tells you, that's maybe a good thing, but the bad news in this is there appears to be a lot of people, and there are a lot of people in California and our region waiting for kidney transplants. So we have to become very innovative about how we can get these patients a kidney of good quality as quickly as possible. As far as our transplant center goes, we did not get there overnight to be 4th largest in the country. This is a little bit complicated slide. It shows over time, starting in the year 2000 all the way to 2012, the number of kidney transplants done per year. And you can see this orange line here. UC Davis has been gradually, or maybe not so gradually, increasing over the last few years, and I'll share with you how we have accomplished that and what our outcomes are with that. And you see the other transplant programs here in Northern California, UCSF, Cal Pacific, and Stanford are listed there as well. Now, we share the same challenges and issues with all other programs in the area here, exposed to exactly the same problems, lack of organ supply, and so on. I've summarized that a little bit for you on this slide. Just a definition, UNOS Region 5, UNOS is the National Organ Transplant Network, or the body that administers that. The United States is divided into regions. Region 5 is essentially California, Nevada, Arizona, Utah, and New Mexico. But if you look at the population, it's really California for most part. So the UNOS Region 5 is listed here. 21%, so these are all patients on the waiting list. 21% of all patients in the United States that are waiting for a kidney transplant are actually listed in UNOS Region 5. So it tells you how populous this area is and how difficult it is to get a kidney transplant. Unfortunately, and that's the bad news, only 16% of all the transplants in the United States are actually done in Region 5. So other regions are doing a little better at getting their patients transplant. You can see that other regions that have lower bars, meaning less patients on the waiting list, are doing almost as many transplants as we do here in California and the neighboring states. Again, it just illustrates the hurdles we're all faced with. And this is also all too well known. At the same time, why there's so many people on the waiting list, such a big discrepancy between people on the waiting list and people getting transplanted, transplant trends in the United States are essentially flat. I don't need to go into details here, but when you look at all these bars, live donor, deceased donor, there has really not been a whole lot of change over the last few years. So where does it leave us? At UC Davis, we had during the same time as many other programs too, a very substantial increase in our wait list. So now you have all the components for a big challenge. You have an increasing amount of patients on the waiting list. And on top of that, you have the organ shortage crisis, which I've shown on the slide before. Many more people on the waiting list than people getting transplants. And this, together with that, could potentially turn into a big problem. So it's a crisis of organ supply crisis in the United States. We're experiencing that too. And so for us, the question was really, do we continue to do business as usual, meaning keeping the transplant numbers flat, or do we look for creative solutions? Now, we went for the second aspect of this, and we sat down and thought, how can we accomplish a higher number of organ transplants while still having excellent results? So we want to make transplant an option for as many patients as possible. That's our primary goal here. During the remaining part of this presentation, we're going to look now first at the deceased donor renal transplants. How do we maximize access of recipients or of patients on the waiting list to deceased donor renal transplants? Now, ideally, everybody that gets a transplant gets a kidney from what's called a standard criteria donor. Now, the standard criteria donor is the highest quality deceased donor, is somebody that's under the age of 50 or between the age of 50 and 60, and that's basically healthy, completely healthy. Now, this is unfortunately rare. It's the exception. Nowadays, because of the changing demographics in this country, as in many other developed countries, the donors reflect nothing but the general health of the population. Population overall is getting older, so there's more donors over 50 years as well. And there's also an increasing proportion of donors that suffer cardiovascular deaths, be it from stroke, be it from heart attack, be it from other causes that are related to vascular disease. And at the same time, the waitlist has shown more than 200% growth. You've seen that on the slide that applied to UC Davis as well. So in our quest to try to get as many patients transplanted as possible, we have looked over the past few years at novel and creative opportunities to maximize access to transplantation. And we've started to use kidneys in a very judicious fashion from what we call non-conventional donors. Now, non-conventional really, for the purpose of this presentation, means mostly it's not a standard criteria donor. It's not your perfectly healthy 35-year-old trauma victim, which is very much the exception nowadays. Nowadays, we're dealing with different types of donor. And I'll go into more detail for some of these categories, and we'll discuss those as we go along. And in addition, we have also introduced, over the past decade, and increasingly applied and generalized the use of a pulsatile perfusion pump in preparation for transplant. I will show you what that is in a moment. Let's first start out with the first alternative. in order to increase the number of potentially available organs. It's by using organs from what's called or defined by UNOS as an expanded criteria organ donor. That's any donor over the age of 60 or donor of age 50 to 59 that has at least 2 of the following: hypertension, creatinine level in the donor over 1.5, or stroke as a cause of death. Now, the ECD kidneys will not work quite as well as the standard criteria donor kidneys. So after 1 year, 8 of 10 ECD kidneys will work as compared to 9 of 10 standard criteria donor kidneys. So the way UNOS has set this up is that you cannot offer an ECD kidney to a very young patient. So at UC Davis, following all these rules and regulations, only candidates over the age of 55 are offered the option to accept ECD kidneys. You need to match these kidneys with the life expectancy and other medical issues that the recipients have. And it's a very tight, federally regulated consent process for these ECD kidneys. You cannot just call somebody up at 3 o'clock in the morning that's on the waiting list and say, hey, I got this ECD kidney coming in tomorrow morning. Do you want to come in? It's not how it works. We must, and that's the right thing to do, obtain the consent ahead of time. So when patients come to our transplant center, they get evaluated by nephrologists. There's an education class by one of our highly skilled nurse coordinators. Patients are informed about that option. They're given a form, and they can ask all the questions they need, and then they can take the form home, and then they're asked if they want to sign up for a potential ECD transplant. They should just mail it back in, and only once we have the signed consent in our hands can we activate them and make them eligible for ECD kidneys on the match list. We have had excellent results, and other centers have had excellent results with these types of donors as well. It's just that we need to very carefully select the recipient population that we would consider for this type of graft. We need to match the metabolic needs of the recipient with the donor kidney, obviously always within the match list that we get from UNOS. We cannot make up the rules ourselves, and that's the right thing to do. ECD kidney or a standard criteria donor kidney from a donor that has maybe a little bit of transient kidney dysfunction, maybe actually a pretty good match for somebody that's on the older side or that's a little more lightweight. When you weigh 250 pounds and very big, then a kidney from an ECD donor may not be the right thing for you. But if you weigh maybe 150 pounds, 160 pounds, your muscle mass and so on is not quite as big, then an ECD kidney, particularly a good ECD kidney, and I'll show you how we identify the good ECD kidneys, may be a good match for you. Now, that's not all. If we have ECD donors, we come across those regularly, that do not have a kidney function that is sufficient to support a recipient by transplanting one kidney, we have the option of doing a dual deceased donor transplant, meaning we're taking 2 kidneys from one adult donor and place these into a single recipient, just to increase the amount of kidney tissue, kidney mass in the recipient to a level that's sufficient to keep that person off dialysis. That's something else that we offer routinely at UC Davis. It takes quite a bit of experience and know-how to determine in which donor you better transplant both kidneys at once versus one kidney only, or whether you actually shouldn't be doing any transplant at all. Because again, the outcomes of any transplant program in this country are subjected to a very significant amount of public scrutiny, and there's a lot of regulation in the transplant field, and again, it's the right thing. Another category of kidneys that we're very successfully transplanting are those from donors that have been exposed in the past to hepatitis B or C. Now, this may sound scary at first, but I think there are ways how you can deal with it, and this is also how UNOS wants this to happen. So if you have antibodies against hepatitis B or C, you can actually be safely transplanted with a kidney from such a donor. So the key is to identify these recipients ahead of time and to have some plans in the back of your pocket. This is nothing you want to do, as I mentioned earlier. You do not call a recipient up at 2 in the morning and say, well, I have a hepatitis C kidney. Do you want to accept that? Same consent process applies as for an ECD kidney. If you're a hepatitis C positive recipient and you want to be considered for hepatitis C positive donor kidney, you need to sign up ahead of time, and you need to mail in your consent form that's signed. Otherwise, we cannot activate you on the waiting list for hepatitis C positive kidneys. Now, why is this such a big deal? Basically, we're having a hard time keeping patients on our list active that are signing up for those kidneys because we transplant them so fast. And we transplant with kidneys that are actually much, much, much better than our average donor. Those are typically good, really good standard criteria donor kidneys, because there's only a restricted amount of recipients nationally that signs up for these. I mean, not every recipient on the waiting list has hepatitis C to begin with. And so this is an excellent means of getting a really high quality kidney, and on those we're actually extremely picky, because by just waiting for 4 or 6 months, you can get a really good kidney. And the same thing applies to hepatitis B core antibody positive donors, essentially donors that were exposed to hepatitis B. We will only place kidneys from such donors into patients that have proven immunity by having a hepatitis B surface antibody in their system, typically from having undergone successful vaccination while they were on dialysis or from earlier in their lives. So, but those are all things that we need to check beforehand. We need to keep a database. We need to be able to identify these patients that are immune to hepatitis B on very short notice. And then with all of this, as always, informed consent is extremely important, not just for legal reasons, but also for patient care reasons, because we want to tell people ahead of time what we're doing. And then another example of these non-conventional grafts, we're really trying to push the envelope and maximize the kidneys that are available, are the pediatric en bloc kidneys. Traditionally, when I trained in transplant 20 years ago, any pediatric donor, any baby donor under 20 pounds would typically not be considered, and organs wouldn't be used. Well, that doesn't work nowadays like that anymore. And we've been pushing this envelope as well, given that the wait list has increased so exponentially. And so what we do is we take these kidneys from these small pediatric donors and leave them together with their vessels in a single block, as the word says, transplant them into the recipient. So you can see here the surgeon's fingers. These are fairly small baby kidneys, and these are the baby kidney vessels that are hooked up to the recipient vessels. And I promise you, this is the only bloody picture I will show you today. Okay, although I'm a surgeon, I like what I'm doing. I know this is not. Now, how can we accomplish that? Well, the reason why so many other programs feel uncomfortable using these kidneys from these very small donors, and I'm talking now donors that are maybe 8 pounds or even 6 pounds of weight, why many other programs are uncomfortable using these is because they don't pump them. Now, we've been using pulsatile pump preservation. What it basically means is when you take the kidney out from a donor, you put it on this pump here that we have at the medical center. In fact, we have 3 of them that can be wheeled around in the operating room when the kidney is ready to be transplanted. And we pump essentially all kidneys, not just the pediatric en blocs. We'll also pump the extended criteria donor kidneys, even standard criteria donor kidneys, because the pump has some distinct benefits. We have a team of perfusionists, of pump technicians that watches these, because sometimes these kidneys are pumped for 24 or 36 hours, because the pump increases the preservation quality. And then you can see on the lower screen, there is a monitoring device attached to it that tells us what the pressure is with which the pump has to pump the blood through the kidneys, and what the flow is. And so if the resistance is very high in these kidneys, for instance, from an extended criteria donor, that would be suggestive of some vascular disease, and we will use the pump and the numbers that we see on the pump to decide whether a transplant is, or whether a kidney is transplantable or not. And we will occasionally discard kidneys and not transplant them and send the intended recipient home if the pump numbers, as we call them, don't look good. So this has become an essential, critical tool, not just for these small pediatric en bloc kidneys, but also for adult kidneys, in order to determine whether they're transplantable. The second big benefit is, and I do not have time to go into more detail on that here, it turns out that putting these kidneys on the pump, and you can see this on this curve here, it mimics the blood pressure curve. It actually turns on some genes in the kidneys, in the blood vessels of the kidneys, that promote the recovery and the healing after the transplant. And that's why there's been a big multi-center randomized trial in Europe was published 3 or 4 years ago that demonstrated unequivocally that pumping kidneys has benefits above and beyond just figuring out whether this is a good kidney to transplant. So this is just an example. This is how these baby kidneys look on the pump. Again, gives you an idea how small they are when you compare it to the fingers of the surgeon. This is just a basic illustration of what the pump can do for you, among other things. Before pumping, you can see these kidneys when they come out of the donors after recovery look pretty mottled. There's still some residual blood in there. If we would transplant this here, there would be a high likelihood of this kidney actually clotting off. This is why a lot of other programs that do not have the opportunity to pump them will not use them. This is after pumping. You can see we literally condition the organ and improve its quality and decrease the likelihood for having complications. You can just compare for yourself the difference in aspect here. So we get better immediate graft function when we pump kidneys. We decrease the length of hospital stay because if the kidney functions better right away, well, then the patients can go home earlier. They don't need dialysis, or don't need dialysis quite as long as they would need otherwise. We can preserve them longer. So if we have a lot of kidneys that are coming in, and we only have 1 or 2 operating rooms available, we can leave the better kidneys on the pump for a little longer without any detriment or any measurable detriment anyways, and still transplant them safely. And it's become a tool, as I mentioned, for safe, and that's really the first and foremost aspect, and increased use of extended criteria donors after cardiac death kidneys, and pediatric en bloc kidneys. So if we look at survival of pumped ECD kidneys versus SCD kidneys. So here we're taking a kidney from an extended criteria donor that's older and has more health issues, and put it on the pump and compare the transplant outcomes of those kidneys with those of standard criteria donor kidneys, younger people, younger donors that were not on the pump. And you can see that 4 years out, this is data from our center, the results are very much not identical, but similar and very close to each other. The difference between SCD and ECD with the pump is much less than when you do not pump ECD kidneys. So we've talked about the novel and creative opportunities to maximize the transplantation, the non-conventional donor kidneys, and the pulsatile pump perfusion. How do we get these kidneys? Because obviously the organ supply, as we all know, is very limited in the United States. And it's certainly also very limited regionally. There's only a finite amount of donors every year. So what we've resorted to is we are importing kidneys from other regions. Importing means just that certain kidneys don't get used by the local transplant centers anywhere in the United States. And then through a computerized organ offer system run by UNOS, by the federal contractor that administers the organ transplantation system, these kidneys get offered nationally. And then in the order of ranking on the patients on the list. And so we are very eager to look at each kidney each time that we get offered. We will bring them in whenever we can get them. We'll put them on the pump. We'll look at them. We'll do another biopsy, or we re-biopsy them, even if they were already biopsied the first time, say in Florida or New York. And this is what our current practice is in 2011. We look at the percent of deceased donor kidneys imported from other regions, and this is kidneys transplanted at our center. And so you can see 64% of our kidneys were actually not recovered in the Sacramento or Northern California area. They were imported from all over the country. We're having kidneys from Florida, from New York, from Manhattan, from Puerto Rico, from Alaska, from everywhere. And you can see the US average is 22% imports. So when you look at other transplant programs, and this is pretty much matched by the other programs in the Bay Area here as well. So that's where a lot of our growth is derived from, is by really looking at each kidney that we get offered through the national match. And so you can see the results of this. Over the last 7 years, our percentage of non-conventional donors, and I gave you the whole list of what a non-conventional donor definition is, has increased from 14% in 2005 to 75% in 2012. So we're not only looking at all these potentially importable kidneys, but we're also looking at all these various categories, hepatitis C, hepatitis B core, extended criteria donor, and so on, every single time. So you're going to ask yourself, we do all this, great. what is the outcome? Because it wouldn't be justified if the outcomes weren't good. Because again, we would get slapped on our hands by UNOS. Again, you can look all these results up on the internet because it's all published and publicly available information. We compared standard criteria donor kidney outcomes versus those of non-conventional donor kidneys, and you can see 5 years out, the results are virtually identical. Same thing applies to patient survival. So if you as a patient are found to be fit or suitable to be offered, you can still decline it, to be offered a non-conventional donor kidney, your survival 5 years down the road is the same as whether you would have gotten a standard criteria donor kidney, which is obviously still much better than having remained on dialysis, because that's the big alternative that nobody wants to go for. You can say, fine, the kidney graft is working after 5 years, but there's a big difference whether the creatinine may be 2 or maybe it's 5. Technically, for UNOS, the kidney is still functioning, but really what matters is the level of graft function. We didn't look at creatinine level, but we looked at GFR, which is the glomerular filtration rate, which is roughly equivalent to the creatinine clearance. So when people say I have 20% kidney function left, well, there's a glomerular filtration rate of about 20. So you can see that in green, those are the conventional donors, and in gray shaded areas, you have the non-conventional donor kidneys. And up to 3 years out, the results are also virtually identical as far as the level of kidney graft function goes, not just whether the kidney is functioning or not, because that's still meaningful, but it's not the whole information. So while we do all this, I think the very important part is we have to do this very responsibly. And so how do we do this? We carefully match specific organs to recipients. I already mentioned to you, regardless whether it has to do with hepatitis antibodies or with recipient age or donor age, recipient weight, recipient size, and so on and so forth. We also very closely monitor our outcomes. Our program has always been very strong on a continuous quality improvement process. We have every week a meeting with all the physicians where we review all complications that we have as anybody else, any kidneys that get lost, any issues that occur, any patient that needs a second operation. That gets reviewed in our multidisciplinary CQI committee. We're very vigilant and we permanently reevaluate our practice. When you've seen this graph where our number of kidney transplants has increased, the practice when we started increasing the number of transplants has not been the same as it is now. Where we're at now is the result of a process over the last 5 to 7 years where we've constantly looked again at ourselves, what we're doing, what should we continue to do, where are there more opportunities, and what should be better not continue to do. And then we think a very important part of this is the close post-transplant follow-up and care. Now, some of these kidneys, particularly when they're imported from the East Coast, say, and they have a long preservation time, 24 or 36 hours, even if we put them on the pump, they may not function right away. And nationally, as is our center, 25% of the deceased donor kidney transplants do not work right away, and 25% of recipients need dialysis for a variable amount of time, be it just a couple dialysis runs, or be it 2 or 3 or 4 weeks until the kidney literally wakes up. That number that we see between 25 and 30% is exactly the national average as well. And I think it's important for some patient, for actually any patient, any recipient, to realize that when you get a deceased donor kidney, there's a 25% chance you're going to go home on dialysis. Now, those patients are obviously complex because they come in on dialysis, they go out on dialysis, albeit for a short amount of time. So a lot of things are changing. Potassium levels are going up and going down. Urine output increases. And so it's key to have a very close follow-up of those patients by our own nephrologists that know what the history of the graft is and what to expect after the transplant. It's all part of a big system. And with that, I want to leave it at the deceased donors, and I want to move on to the live donor renal transplants, because we have not only tried to improve access to transplantation by pushing the envelope and trying to develop new means of finding deceased donor kidneys, but we have done the same process and principle, have applied that to the live donor renal transplants. Just for those that are pre-transplant and that are still considering their options, I think you probably have heard this for many other sites by now, but the live donor transplant still by far remains the best transplant option for anybody that requires a transplant. It obviously obviates all the issues with the huge wait list because you have immediate access to a kidney graft. If you are pre-dialysis, as Linda asked earlier, if you're pre-dialysis and you have a live donor and you don't have to wait, well, then a fair amount of those patients can actually get transplanted before they ever go on dialysis if they have a live donor. You obviously minimize the issues associated with dialysis, the infections, the mortality, access issues, fistulas, grafts that are clotting, or peritoneal dialysis, catheters to get infected. And importantly, once you have the transplant, if you have the good luck of having a good chance of having a live donor, your graft will last on average twice as long if you have a live donor graft as compared to having received a deceased donor graft. Even with a standard criteria donor deceased graft, you have around 9.5 to 10 years of graft half-life. With a live donor, it's around 18 years. So on average, a live donor graft will last for 17 to 18 years. Deceased donor is somewhere between 8 and 10 years, depending on what the donor quality is. And this is just illustrated on that slide. The same thing that applies to any other transplant center in this country or in the world applies to us too. When we look at our live donor results in over 1,000 kidney transplants over the last 7 years, and compare that to the deceased donor grafts in the standard criteria and the extended criteria donor categories, it's by far better. So, how do we optimize access or try to make it as easy as possible for patients to find a live donor? And I think it's very important to point out that we have a dedicated live donor team. We have a dedicated live donor physician, a transplant nephrologist. We have 2 dedicated surgeons doing nothing but, well, no, we're not doing nothing but we're doing exclusively, we're the only surgeons doing the donor nephrectomies. So we concentrate the experience in the hands of a few rather than having everybody do it, and perhaps then having to be more selective on the donors when they present with anatomical variants and things like that. We have 3 nurse coordinators, 2 full-time, 1 part-time, dealing with live donor coordinators. I'm very happy to say that Michelle Sturgis, whom you've met earlier, is going to be joining the live donor team soon. We have an independent live donor advocate, which is a social worker, and then we have also administrative support staff, one of them Spanish-speaking, that deals with nothing but live donors. So that's a pretty substantial team. So that certainly makes it easier for patients by knowing with whom to speak, both the recipients and the donors. We do targeted recipient education to point out the benefits of live donor transplantation, because a lot of patients obviously have a lot to deal with when they develop kidney failure and they've never heard about it. What seems obvious to probably most of you here, that live donor is a better option, is not obvious to somebody that just gets slapped with diagnosis of chronic kidney disease. So I think there's a lot of information deficit. That's why associations like yours are crucial in this, to disseminate that information among patients, and even better if you have the opportunity to talk to recipients of such kidneys. And another important part of the education is, how can I ask my live donor? We've found over the years it's difficult, understandably difficult, for many individuals, regardless of what their background is, to ask their friends or even a family member or brother or sister, would you consider donating? And so we have some pointers, and as part of the education, we also have a nurse calling patients ahead of time when they get referred to our center, just to inform them about all the options of living donation. And it's a very big part of the recipient education after referral when they get evaluated for a transplant. So we don't steer them by neglect, if you will, to the deceased donor list. So, and then lastly, we have also, as any other transplant center, donors that come with recipients that come with a live donor, but unfortunately they're incompatible. Be it because they have a lot of antibodies against the donor, or that the recipient and the donor are not blood type compatible. We have options for those available at our center too. It used to be 10, 15 years ago, these donors would typically get turned away, or the recipients would get turned away and say, well, we're sorry, we can only list you for a deceased donor. transplant. However, nowadays there are many other options. We do, within a somewhat restricted range, some desensitization. I'm going to talk about that in a little bit. In donors, in the recipients that have a donor-specific antibody, yet a compatible flow cross-match. We do IVIG infusions on those. Actually, the transplant tomorrow was facilitated by that because the recipient is actually sensitized against the donor. Well, what we think the better option is, if at all possible, is what's called the paired exchange transplants, where we match up incompatible donor-recipients pairs with each other, cross the donors over, and then you may end up with a compatible combination. We can do that within our center, and we also are very active participants in national registries for paired exchange transplants. You may have heard about the National Kidney Registry, for example. We've been involved now for several years and have been very active with them. We also then facilitate national chain transplants through these organizations. We've routinely removed kidneys, recovered kidneys from donors at UC Davis that we shipped to the East Coast, and likewise we routinely received kidneys from the East Coast or from anywhere in the country, from Utah or Texas or Florida, as part of these national chains. One of our live donor coordinators works a good part of her time just on that, because this is, as you would imagine, very onerous in terms of the time commitment in order to get the logistics straight and make it all happen like clockwork. This is just a very brief illustration of what the kidney pair donation is. You have donor one, recipient one, they're incompatible. This is the red cross here, the same thing for the second pair. And then by crossing them over, be it the blood type that's different in the two donors, or be it that the donor has a different tissue type, these can become fully compatible, and you do not need desensitization. Whereas if you had pursued this and this, you would have had to desensitize twice. And there's also various variations on this theme. And I will not go into any more detail. We did one at our own center, UC Davis, 4-way, what we call domino transplant, where we had 3 donor-recipient pairs that were fully incompatible with each other. We had a non-directed, altruistic, Good Samaritan donor, as he also called, step forward. Actually, he was actually from this area here too, who wants to remain anonymous, who donated to the first recipient, and that essentially unlocked this domino transplant, and the last donor gave to one of the recipients on our deceased donor waiting list. So we did, in a matter of 48 hours, these 8 surgeries, 4 transplants, with a big success. And these are these individuals. The donor that started all this didn't want to be on the picture. You have the flower bouquets in the hands of the actual donors. So he received the kidney from the non-directed anonymous donor. His wife gave the kidney to this gentleman here. His brother gave to this man, and this man's wife gave to this person that was on a deceased donor waiting list. And this is our live donor coordinator, Sharon Stenson, who unfortunately cannot be here today. Another big part, to finish off on the living donation, is the minimizing the disincentives for the live donors. Sounds bad, but the fact is, a live donor, I've been in this field for over 25 years now, and been doing live donor transplants for that entire amount of time. So I know what I'm talking about is that you have essentially a healthy person that gives up a kidney, and anything you do to them, even if it's only a half-inch incision, is actually a disincentive. And so the less disincentive we can have, the better it is, because those are people that are healthy. They don't need that operation to begin with. If you look at it very critically, they have lives, they have jobs, they have families, and so we need to get them back into that as quickly as we can. And so we've constantly worked at UC Davis on trying to improve and to optimize that technique. We did, as everybody else, open nephrectomy, and I'll show the big incision from the program start to 1997. Then my senior partner, Dr. Richard Perez, was the first one on the West Coast to do a laparoscopic donor nephrectomy when this technique, minimally invasive technique, became available in the wake of when this was made possible for gallbladder removal or colon removal. It took a few years for the transplant surgeons to apply that to the donors as well. And so 1997 was the first one. So we've had a 16-year track record now of laparoscopic donor nephrectomies. I will save you the technical details. That suffice it to say that Over the last 10 years, we've tried to adapt and modify the technique. And most recently, we've been very pleased with the latest iteration of this. Since for the last 3 years, we've done it through a single 2-inch incision, basically at or in the donor's belly button to remove the kidney. And I'll show you that in a moment. So this is the past. Some of you may have seen this or may have relatives that have donated a kidney. I don't think I even recall the last open nephrectomy I've done. That's probably over 13 years ago. We just don't do these anymore. The more traditional laparoscopic technique that has been around since 1997 is this here. So this is a patient on your operating table. The head is to your left and the feet are to your right. And you can see there is a short incision here where like a C-section would be done. That's where the kidney is removed, because this operation we need to pull the kidney out, still in transplantable condition. And these are these three, and the fourth one here are the sites where we put these laparoscopic ports in, where the camera goes in, and the video camera goes in, and the instruments go in. So, but again, we were not happy with this, although this was already a very good progress. I will not present you here a lot of scientific papers, actually any today. This is the only table you'll get to see. This was in 1997. You can see what a big leap that was. Length of hospital stay in the surgeon that in the series of the surgeon that pioneered this procedure. With the open nephrectomy, hospital stay was about 5 to 6 days, and donors worked out pretty crooked, because I got trained in open nephrectomy, so I've seen a fair number of those. And then with the laparoscopic technique, it was cut essentially in half. The same thing applied to the ability to return to work, which was 6 weeks with the open technique and cut down to 3 weeks with the laparoscopic technique. Obviously, it depends on what kind of work you do. Is it physical? Do you work as a carpenter on a construction site versus do you have more an office job, or you're self-employed at home? There's obviously variations to this, but it gives you, in general, the trend, what the laparoscopic nephrectomy did. Now, as I said, we were not, over the years, satisfied with this. We tried to improve our techniques even further. And so the present and what we think the future of this is, at least for many donors, not all of them, but many donors, is what's called a single incision nephrectomy. So it's just a single incision around the belly button that could be shorter if we just want to do the kidney dissection, but we need to make really the length of the incision is driven by the need to get the donor kidney out unharmed so it can still be successfully transplanted. We've been doing that since 2010. I'm not going to give you really any technical details. Suffice it to say that it was made possible by technological evolution. There's what's called a single-site port or gel point port. You can see all the instruments go in. You get the idea with this kind of this amount of instruments here. It's technically much more challenging than a conventional laparoscopic procedure. The head of the donor is here, and the feet are down here. If you just look at all the cables and tubes and instruments going in here, it takes a fair amount of coordination. Inside, this is the same. This is the spleen. The diaphragm is here. Those are the instruments. The kidney sits underneath here. So this is what it looks like. Compare that to that open incision on this gentleman that I showed you initially on day 30. And this is a different patient 5 months down the road. Very different compared to others. I'm only showing this slide here to make the point. You can see this man or this patient, he's a pretty big guy. He's muscular and he's got a little bit of stomach. And we do it even in those patients. So we're not picky saying, wow, we do a new procedure, but fail to mention in the fine print, we only do it in people that have ideal body weight, BMI of 25 and less than 120 pounds. No, we offer it to everybody, and I'll spend a few words in a little bit on what our criteria are. I want to finish this laparoscopic nephrectomy section off with this email from one of actually our first single-site donors in 2010. He wrote to Sharon Stencil, whom you saw in the picture. Hey Sharon, ridiculous Superman pose, but I felt that good today. He did this 7 days after donating a kidney for his wife. This is actually in the Santa Cruz Mountains here, not very far from here. So that is for us as surgeons very important and very rewarding, and is worth the extra work to do this. So in summary about live donor renal transplantation, this is by far the best transplant option. The laparoscopic single incision nephrectomy technique is now our preferred surgical technique. We offer it, I would almost say, as a default technique to more than 95% of our recipients. Very, very few individuals will be offered the traditional technique if we think they may be better served, and most importantly, the operation can be better done, more safely done through conventional means. And the benefits are obvious. Now, what's obvious to everybody is less scar, but I think what's important to me is, and the donors obviously too, is there's less pain and a faster recovery. People can get back into their lives faster. They can be with their families, take care of their families, get back to their job, or go on with their lives, whatever they want to do. The other intriguing question about this is that has not been answered, since it's a very new procedure that's done at our center and a few other centers, is does it increase the live donation rates? Because one of the inhibitions that some recipients have when they ask a potential donor is they don't want to inflict more pain or scar or incision or recovery than absolutely necessary. And one aspect that's going to have to be answered by future research is whether having an even less invasive kidney removal method available makes it easier for recipients to ask potential people that might be able to donate to them. And I think that is actually, if I as a surgeon could contribute to that, get more people transplanted that way with really good quality kidneys, I think that would be an extremely satisfying, positive aspect for me. I want to finish this presentation off. Now, there's been a lot of data. We're going to go slide by slide through the questions that the board of directors of BAAKP has forwarded to me. And some of it is just going to be recapping information I've given you. That's on purpose. And then some others will just give some free answers. And I'm going to ask for the second half of this Michelle Sturgis to come up, because she's much more qualified to answer some of those really pertinent questions than I am. What is the average waiting time for a kidney at UC Davis for our blood types? Probably the most burning questions that goes through the mind of many of you. It's a little bit complicated, but I will spend 1 minute on explaining the details on this slide. UNOS does not publish waiting time by blood type by transplant center. We can make a data request, it's public information, but it takes weeks or months to get that answer, so I was not able to get that specific answer beforehand. What UNOS publishes is the median time to transplant. That means for patients that got waitlisted between January 2006 and June 2011, how many months does it take on average for people to get transplanted? And when you look at UC Davis, it took 3.6 years until 50% of those people were transplanted. Or the mean waiting time for them was 3.6 years, and that's for all blood types. When you look at the national average, it's slightly higher. It's 4.5 years or so. And then when you look at the other programs here in Northern California or in the Bay Area, they had not even reached, by the time UNOS did the analysis, the 50% mark. So at that point, less than 50% of patients that got waitlisted in that time were transplanted. So we know already that the waiting time, no matter what, even if you transplant everybody next week, is going to be longer than 6 years. So, which matches about what we know from patients, since we all know these programs. They're all good colleagues of mine. I trained actually together with a lot of the surgeons. We share residency memories. They usually, my understanding is here in the Bay Area, the average waiting time, particularly blood type O patients, around 7 years. Whereas opposed at our center, it's more for 3 to 4 years, and oftentimes even shorter if you qualify for extended criteria donor kidney, for hepatitis C positive kidney, and some of these other categories. So I think that's a very big difference. And again, this is all public data. I'm not making this up. You can all actually access that yourself. How many kidney transplants are performed every year compared to other transplant centers? I've shown you this slide. Nationally, other transplant centers nationally were number 4 in the country. When we just look at the deceased donor kidney transplants, we're number 1 in the tie with UCSF, and this is also the comparison to the other Bay Area programs. This is UC Davis here. What is the success rate of transplant? What is the definition of success? How does that number compare with other transplant centers? Well, let me say a few words. When you are a patient that just gets diagnosed with chronic kidney disease and is evaluated for a transplant, What matters to you is not only what the outcome at your transplant center after transplant is, meaning what is the graft survival at 1 year, at 3 years, at 5 years, or at 7 years. What really matters to you is a life or death question. How fast can you get transplanted? So really what you need to look at is a composite score, as I call it, as a patient. You need to look at each individual center's waiting time, or the death rate on the waiting list, plus the outcomes. If one is really bad and the other one is really good, may not do the job. If both are really bad, it's obviously not a center you want to go to. And there's variations in between. The ideal center has a short waiting time and good transplant outcomes. When we go through these results, keep that in mind, and that's why I'm presenting both the pre-transplant phase and the post-transplant phase, because that's what matters to a patient that gets diagnosed with chronic kidney disease. So, percent of adults on the waiting list transplanted per year. You wanted a comparison with the other programs here in the area. So, we transplant over 25% of the patients listed on our waiting list each year. US average is about 17, and the other programs here in Northern California are below 10%. Again, publicly available data. Similarly, not surprisingly, the percent of adults on the waiting list that died per year in 2011, according to UNOS data, at UC Davis was 3%. US average is 6%, and the numbers for the other programs in Northern California are somewhat higher. When we look at 1 and 3 year kidney graft survival for adult recipients, so that's after how many percent of the kidneys are still functioning after 1 year and after 3 years. You can see that for UC Davis, the 1 year graft survival is 94%. For most other centers for the other centers in Northern California, it's 96%. So our 1 year graft survival is a couple percentage points lower, but it's exactly at the national average. But when you look at our 3 year graft survival, it's higher than both US and the other regional centers. And that has probably to do, we don't quite know yet why, but it has to do with the fact that if a kidney doesn't work in our center with the way we look at organs, we accept organs, it will declare itself early in the first year, as opposed to slowly failing up until the 3rd year mark. Because our long-term results, as you can see, the 3 year here is the lighter bar, were actually higher, both nationally and from a regional perspective. And the same thing applies to patient survival at 1 and 3 year, where actually at 3 years, with the exception of one center, Stanford, we're basically at the same level or even a little bit higher. And we're definitely much higher than what the 3 year graft survival in the US average is. And some of this may also have to do with the fact how patients are selected, and we'll see whether we can get to that, the waiting list. The outcomes of those kidneys are obviously, if we measure success by kidney graft function, the glomerular filtration rate or the creatinine clearance is very good because it's the same regardless what type of donor kidney you get. How is the UC Davis transplant program different from other transplant centers in the Bay Area? Well, I've shown you this list by our novel and creative use of kidneys from donors in these categories. I'm not saying that no other center anywhere in the country doesn't do these. I think what distinguishes us from the other programs regionally is the fact that we actually systematically consider donors in all these categories. Other programs may be looking at this subset here or at this subset here, but very few people look at every single kidney every single time, regardless whether it's offered from Puerto Rico, from Florida, from New York, or whether it's from a donor here from Modesto or from Chico. That's the difference. And the second difference, we are routinely, for all kidneys, using pulsatile pump perfusion. We have 3 pumps available. We have a team of 24/7 perfusionists available, and I explained the benefits of the pump, both short and long term, and also with regard to safe selection of grafts to you earlier. And it's personnel intensive, it's labor intensive, it comes at a cost to the hospital and the transplant program, but we think it's an essential component. And the cost aspect is the reason why the pump is not used across the board in the United States in the way we do it by every single program. So we feel very fortunate that our hospital lets us do it, and we appreciate that opportunity. I also showed you what's very different for us is that we have 75% of our transplants are these non-conventional donor kidneys, consistent with what I told you that we look at all categories of non-conventional donors. And then another very interesting number, as I mentioned, is the imported kidneys that distinguishes us in a very significant way from the other transplant programs here in the Bay Area, where the national average is virtually identical, is around 20% imports. We do 64% imports for our deceased donor grafts. That is a very big difference that allows us to access a whole different and additional pool of donor grafts. The other thing that's different, again, this is recapping the information I already talked about, the percent of the adults on the waiting list transplanted per year. We have a very high rate of transplants per year. And again, I'm not saying other programs are not good or anything. I'm just saying other programs are good. It's national average. It's great. Very good, excellent programs. But I just want to point out that our number is certainly in a very favorable range here. Same thing applies to the deaths on the waiting list per year. We have actually the lowest number of deaths on the waiting list compared to both the US average and the regional average. As far as switching gears to the living donor transplants, what are we doing different compared to other programs here regionally in the Bay Area? We actually offer routinely the single-site donor nephrectomy to our donors, which is very few programs actually in the United States are doing that. There's one in Texas and one in New York that I'm aware of that do this. Desensitization, we talked about this. Our desensitization program is on the conservative side. I want to say that for full disclosure. I don't want to raise any false hopes. It's a very tough subject. We think sensitized patients are best transplanted through paired exchange, if at all possible. It's a very difficult and costly, particularly with patients on the deceased donor list, because you don't know when a transplant is going to happen. So you cannot just desensitize them. If they wait for 2 or 3 or 4 years or even half a year, the desensitization is gone. So we use virtual cross-matching techniques on the UNOS list to maximize opportunities for those donors, for those recipients that are waitlisted for deceased donor graft, for finding a matched donor kidney, so they do not need desensitization. So for all practical purposes, I want to point out that if you have been evaluated here in the Bay Area by one of the other centers for desensitization, and desensitization was not deemed feasible or reasonable, if you get evaluated at UC Davis, we will in all likelihood come to the same conclusion. And we feel that there's a couple centers in the country actually that are really have a big experience with desensitization, namely Cedars-Sinai in Los Angeles and Johns Hopkins on the East Coast, and we sometimes refer patients there, particularly those that have 100% antibody level. Well, let me then very quickly, yes, we do senior kidney recipients. We just transplanted an 80-year-old recipient with a deceased donor kidney 2 or 3 weeks ago. Yes, you have to be biologically very healthy though. What can you do to improve their chances? Sign up for an ECD transplant. What's different? Workup of candidates. We need to work patients up front since they're likely to be transplanted very quickly rather than waiting for 5 or 6 years. So once you go on our list, you need to be ready to be transplanted. Then I was going to have Michelle go over this here. Cost of tests required, we'll do it at the end. And we'll just pull those up again. So I had them all here. I appreciate, we run a little over, appreciate your patience. And I'm available also afterwards for questions. You can just, I'm not going to run away.
Why don't we take a few questions now?
Yeah.
A few questions now, and we'll just shorten that question and
Yeah.
answer period.
Yes.
I got evaluated at Barnes in St. Louis. Do I need another evaluation at UC Davis?
Yes, formally yes. You need another evaluation because each transplant center has their own criteria, their own level of comfort with certain things. We also need to know all the details about our recipients because, as you can see, we need to find the best possible kidney. And that's sometimes also driven knowing what the medical problem of the recipient are.
But all your tests may not need to be repeated. All of your testing may not need to be repeated. If it's done fairly recently, we would use those results.
Okay, great.
Yes?
Yeah, I was curious about the hepatitis B and C. if you, let's say the antibodies all worked out and so on, but then you were taking immune suppressing drugs afterwards, and for some reason the kidney failed, would you then be less likely to be a qualified recipient of another kidney transplant because you've had exposure to hepatitis B and C?
No, because you already had exposure to hepatitis B and C respectively to begin with.
Because you would have had the antibodies.
You've had it before, yeah. So that will not change your antibody level or qualifying for another transplant. Now, if your underlying hepatitis C disease progresses and you develop cirrhosis now, independent of your transplant, you may not be a candidate anymore. But it has nothing to do with the first transplant.
And as far as just the best thing you can do to, in a sense, be a qualified candidate, if you're just talking in general, to become a recipient of a kidney, what would you tell your patients the most important things to do?
The most important thing is maintain a good functional status, meaning exercise, walk. If you're wheelchair bound or sitting on the couch the whole day, that's difficult because you lose muscle mass. You need to have the stamina to withstand the transplant surgery and what comes thereafter. So good health maintenance and maintain physical activity and functional status.
Okay.
Oh, more questions?
How does the number of people on your waiting list compare with the other California institutions in Northern California? Do you have different criteria than they do? Is your list stricter in some way?
Yes and no. Because the other centers here in the Bay Area, there's about 7,000 patients listed in the Bay Area here on the national waiting list from all the centers. We have about 1,000 in Sacramento, so it's always shorter. The other answer to that is because the waiting time is so long in the Bay Area, 6-7 years easily, depending on the blood type, these patients get listed and they get worked up after 5 or 6 years because a lot of things can have changed. So there's no point doing a big workup up front and then come back 5, 6 years, 7 years later for your transplant and needing another workup. For us, and so they get their workup in all details towards the end. Whereas with us, because our waiting times are short and it also is more complicated, some unit regulations, we do a complete workup up front. So on the surface, we appear to be more picky, but we need to be able to accept recipients that are actually transplantable within the next year or 2 or 3. As opposed to saying, oh, we're going to list you, and then we're going to look at you in earnest in 6 years and see how you're doing then, whether you had any other health issues. So yes, our criteria are different because we're forced to list recipients in an actually transplantable state.
For this question, the cost of the test, let's say if I had the test done before I went on Medicare at another place, UCSF for example, then I want to be on the list for UC Davis. Can I request for Medicare to pay for this second battery of the test?
Yes, Medicare does not restrict you from having additional tests at a second center.
So they'll pick it up.
Mhm.
Because I was private insurance previously, and now I'm on Medicare, so I was just wondering if Medicare will pick up the whole thing.
Yes.
And for the follow-up care, you're saying that we don't have to go all the way back to UC Davis for care if the Walnut Creek will be the closest one?
For the first 90 days, you'd have to go to UC Davis.
How many visits are you?
For the first month, probably once a week, and then it would go to every other week, and you probably would have a total of somewhere in the vicinity of 8 visits to Sacramento.
We'll have one more question, that's
Yeah.
back, and we have to move on.
Yes, do you count the kidneys also for the paired exchange program process?
Can you repeat the question?
Yes, the question is, do we also pump the kidneys for the paired exchange process? Is that
Yes.
correct?
Yes.
No, because the kidneys for the paired exchange process are all invariably living donor kidneys, and they are of such good quality that even if we know already the donor has been worked up extensively medically, so we know it's a good quality kidney, and because it's such a good quality kidney from a younger, healthy person typically, we can keep these kidneys 12, 18, 24 hours on ice without pumping. And you put them in a recipient, and it's amazing to see how they pink up and they start still working immediately. And that's why we don't put them on the pump.
I guess one more.
That you work in Section 5 of the nation. do all of those states in Section 5 work together? In other words, you look outside of the state as well, with the other transplant facilities, or you all on your own?
Well, the programs are on their own, but we get the Region 5 means, what it means practically is that kidneys that get recovered within Region 5 by a local center and don't get used locally first get offered to the region. And if the region doesn't use it, then it goes out, gets offered nationally. So if we import a kidney from outside Region 5, it means that neither local transplant centers elsewhere nor any other region in the country would want to use it. So that's how it goes from local to regional to national. That's the allocation scheme. For deceased donor kidneys. For lab donor kidneys, you show up with a lab donor at the transplant center and you get your transplant.
Do each of your centers use their own methods of operation?
Yes. What I described here to you is our way of doing transplants. There are obviously the transplant surgery and immunosuppression is very comparable, but again, in terms of recipient, donor selection, and so on, there are differences between the transplant centers. Yes, absolutely. That's why there's different transplant rates, different wait list, mortality rates, and so on.
Thank you, Dr. Troppmann and Michelle Burgess.